So it is my honor and privilege to welcome our guest speaker for today's TBIF, Professor Yang, who's a research scholar at the Alzheimer's Disease Research Center at Washington University in St. Louis. And he's published more than 200 manuscripts on dementia and dementia-related fields, and has been awarded the Innovation and Impaction Papers 2013 World Biomedical Frontiers Award. He's also initiated the Asian Society Against Dementia collaboration studies, including AD8 Asia, to screen early dementia and the registration of Alzheimer's disease in Asian countries, and foster collaboration on dementia in Asia. Meanwhile, through the worldwide institution for Gung Shan, he has held more than 100 dementia-related training programs all over the world. And he's also served as the editor and reviewer of many journals and many international professional societies and associations. So we are really honored and grateful to have Dr. Yang with us today. Thank you so much for being here. Today we are going to do things a little bit differently. Dr. Yang has pre-recorded his talk for us. I will play that. It's about 37 minutes, and then we'll have some time for a Q&A afterwards. And just a reminder to please make sure that you remain on mute for the duration of the presentation. Thank you.
Saiba, Dr. Yang, would you like to say a few words before we start?
Okay, thank you for the kindness for the moderator. And I would say, given to the pandemic situation, we cannot meet side by side and face-to-face to discussion of dementia. But I hope in the near future, we can meet all of you at American and at any side in the Gung Shan. Today, I will share our experience in dementia. All of us know dementia is a disaster of current situation. And from Taiwan to the world, we have developed several screening tools how to detect dementia. And in the final section, I will share with you the meditation to dementia. And currently, the new study published in MIT and Harvard, then use meditation to treat dementia, and they have some fruitful results. So also, I will share this data with you. After the pre-recorded video, we can discuss online. And then thank you for your watching. Thank you so much.
Thank you so much.
Thank you.
Okay.
Gentlemen, I'm Professor Yuan-Han. It's my pleasure to share our experience in the dementia research. Today, I will focus on risk assessment and the prevention of dementia. I come from Taiwan. The Neuroscience Research Center was established under the supervision of our university. We have 5 parts: the dementia and the neurodegenerative disease, cerebral medicine and epilepsy, neuroscience and AI, cerebrovascular disease, traumatic brain injury, and neurointensive care. Also, we have collaborated with several universities, the Hong Kong University of Science and Technology, the Washington University in St. Louis, and we also have worked together with Taiwan National Health Research Institute. And the research center also collaborates with several hospitals. Then we can work together to explore the real face of dementia. As we know, the global impact of dementia is very severe. One patient will found every 3 seconds, and triple to 152 million by 2050. Most of people come from low and middle income countries, and we know that most people of dementia will come from Asia in the near future. For dementia, the WHO have proposed 7 stages to management of dementia. Firstly, we call it pre-diagnosis. It's a very big problem in the world because many patients did not recognize the deficit of cognition function and then attribute the deficit to aging, not demented. Therefore, most people were delayed diagnosis. The increasing public awareness for people to recognize the symptoms of dementia is very important. If we can do so, we can shorten the time gap between the diagnosis and the people awareness. So the first one, the pre-diagnosis stage, the public awareness is very important. Second one is diagnosis. This one also is very important too, because we have to find a quality physician, a special neurologist, who is a specialist in dementia and who can recognize the symptoms of dementia and can treat, diagnose the dementia. It's not easy in the world. And importantly, after diagnosis, we have to find some information and support for patients of dementia. This support are going to support the caregiver in the family, because the caregiver for the dementia care, we are suffering for the queer behavior and the symptom of dementia people. If this patient have demented, the side effect of medicine and the complication of this disease we call behavior and a psychological problem will disturb the caregiver. So the support of the after diagnosis is very important. And importantly, if this patient and caregiver cannot support well after the diagnosis, the community service and the coordinating system and the care management are important to support the caregiver. And eventually, the continuous care and also end of life for the palliative care. So I will say this is a journal of a dementia patient. How about a patient journal? You can see this way. The step 1 to 4 is quite important because it takes time. Many people in North Europe and also I think in America, it takes 6 to 48 months to have diagnosis and treated in the hospital. So if you are fortunately, if you can make a short gap to 6 months to the treater and the diagnosis, it will benefit for patient to the early 80. But unfortunately, if you are too late for the diagnosis, you will go into the hospital, become a late 80. And they have two different pathways for the early AD and the late AD. So how to increase the public awareness to shorten the gap between diagnosis and the public awareness and the symptom is important in today. So that's why we have this teaching and a lesson to public and to all of you to make you understand the symptom of dementia. So we hope to shorten the gap between the symptom and also pre-symptom and diagnosis. And after diagnosis, there are many pathways in hospital. Some hospitals take time. For instance, if you take an MRI in Taiwan, sometimes it takes 1 month or 3 months. But I think in the American or in North Europe, it takes more longer to take an MRI. So once you have a diagnosis, you need many support care and also many palliative care. So this issue are also important for the modern treatment. Currently, the underdiagnosis and the delayed diagnosis represent substantial unmet need in AD. And you can find high proportion, nearly 50% of people report that they need early diagnosis. And also have 50% caregiver report that an early diagnosis of AD would have been preferred. What's the problem to this situation? Patient experience range delay during diagnosis. The factor could be related to the caregiver, the primary care physician, the person of it demented, and the health care system. What happened in the gap between diagnosis and the treatment and the symptom of dementia? Most people currently living with dementia have not received a formal diagnosis. In high-income country, even in high-income country, only 20 to 50% of dementia cases are recognized and documented in primary care. So if you are in a middle-level country or low economic level country, you cannot imagine what's the gap will become bigger and bigger. Denied patient access to treatment, care, and organized support that getting a formal diagnosis can provide. So the formal diagnosis so far is absolutely necessary to a dementia treatment and care. This picture is very important. It will tell you the contribution of Alzheimer pathology and the CVD, cerebral pathology in your brain. You can see the red color here. The contribution of Alzheimer pathology will increasing after 60 and going to increasing and drop after 90. It means if you are getting older and older, after 95 or after 100, you can escape the attack of Alzheimer's dementia. But unfortunately, you cannot escape the attack of blue color, the cerebral vascular disease. Between these two major pathological findings, you also can find some small event of particular demented, frontotemporal lobar degeneration, diffuse Lewy body dementia, and the hippocampal sclerosis. The hippocampal sclerosis represents the hypoperfusion and the aging of your hippocampal structure. That structure is responsible for memory. What is called demented? It's important to recognize the dementia definition. It means an acquired symptom of decline in memory and other cognitive domain sufficient to affect daily function. So here we are going to mention again that dementia is not only focused on memory, it also will affect other cognition domain. How can we detect the change? There are two methods. We call it intra-individual change. You can compare your status to your previous status. If there are change and this change will affect your daily living, you are possibly have demented. And second one, we call it inter-individual difference. You can do some testing and you can compare to the other people whether you are lower testing score or higher testing score to the mean of comparing other people. That's another way to detect the possibility of dementia. There are 10 factors we have to consider before going to the diagnosis of dementia. The 10 factors also tell you that we are mimic dementia. The first one, Alzheimer's dementia, Alzheimer's disease. Second one, vascular dementia. Third, some drug medicine, especially the antipsychotic anti-agent or sleep pill, will contribute to the dementia. And also the depression, delirium, the alcohol use, the metabolic, especially hypothyroidism in the elderly people, the thyroid, the diabetic condition, and some people cannot hear well, watch well. This should be improved because the improvement in hearing and in watching also will improve the cognition function. And other degenerative disease, the tumor, infection, or autoimmune disease. Therefore, you can see in this slide, there are many reasons or causes will contribute to a dementia. So it's not easy to document a demented. If we go to a physician, we need to tell this possible cause to dementia, and also have to recognize it. This picture will show us the different causes of dementia in young and late onset dementia. The cutoff points for young and late onset dementia is age. We use 65. If you are going to more than 65, we call the people have a late onset dementia. And if you are going to have a younger than 65, we call it young onset dementia. But importantly, you can see the distribution of pathological finding of Alzheimer is also the biggest one in young onset and late onset. This picture is the late onset dementia. Alzheimer contribution, the proportion will be 62, and other one is vascular and other cause. But for the young onset dementia here, Alzheimer is still the most part. And other contribution, the vascular dementia, frontotemporal dementia, and other related other cause to dementia, we are also increasing proportionally. We have two measures to tell you possible dementia if we are to a screen. We use a screen tool, we go 88. The 88 is a very simple question, just only a question. If you have two questions change, now you possibly have a dementia status. The screen tool originally come from Washington University in St. Louis, and I translated the tool and spread it to the Asian country, to the Europe country. So this copyright but used for free. You can watch the training video in YouTube. And also another one is an important tool for the staging and diagnosis of dementia. We call the CDR, Clinical Dementia Rating. This tool also comes from the Washington University in St. Louis. I also have translated this tool into Mandarin and spread it to the Asian country. If you are interested in the dementia screen with 88, in the dementia staging or diagnosis with CDR, you can enter the YouTube to watch the training video. What we call the demented, the senior dementia. The dementia we call senior dementia is defined by its age. If you are older than 65, we call it senior dementia. But senior dementia have many complex causes and reasons. The most higher proportion of senior dementia is Alzheimer's dementia. When we're talking about Alzheimer's dementia, we are going to discuss three domains we call A, B, C. The patient may be impairment in activity of daily living. He cannot dress well, he cannot count money, he cannot call a cell phone. The second one we call B, is a behavior disorder. The patient may be presented with a delusion, the agitation, the hallucination, and some queer behavior. And the behavior change will be most disturbance to family and to a caregiver. And then behavior disturbance are usually the most important reason for patient be sent to the nursing home. The third part we call cognition. The cognition is a broad spectrum of a mentality disorder, including the memory problem, the visual spatial function, the poor attention. So if you are faced demented people, you are going to check the ABC. What happened to the brain? In demented brain here, the total weight could be 70-100 grams, depending on the severity of dementia. For a normal brain, it could be 1.2 kilograms. So I would say that demented is true disease, not a phenotype of demented. The brain is atrophy. And you can do the pathological finding, that the two features of Alzheimer's pathological finding. The one is a senile plaque. It's a deposition of abnormal beta amyloid. The second one we call the neural fibril tangle. It results from the death of a neuron. So the cytoskeleton of neuron collapse and lead to the neural fibril tangle. This study is very important. We can watch here, we call demented stage. With different color line, it means different biomarker. You can see the red one, the beta amyloid. We have talked before, it's the most important biomarker of demented people. You can see when you are cognition normal, you will increasing in your blood and in your brain. And eventually, when you are very mild dementia or demented, it's stationary, no change. It means the pathological problem is occur more younger, more earlier, before the onset of dementia syndrome. So far, we are working for here to detect the early change of beta amyloid in brain or CSF or blood, to find the possible people to demented AD and do some intervention. The second one we call tau. Similarly, the cognitive normal, the tau is increasing. And if you are demented or very mild demented, it's no significant change here. So for currently all study, we focus on preclinical. Even if you are cognition normal, we are going to test whether you are under the path of developing dementia. This one we call MCI. During the past years, most of the study focus on MCI to try to stop the evolution of this pathological finding of MCI to demented. But unfortunately, most of our study are not so well. So far, we are working for these two steps. Another very important issue here, I'm going to report with you, we call it adult children study. So far in the world, there are two sites working for adult children study. One is my site. The other one is at Washington University in St. Louis. What is it called adult children study? In our past study, we have found that Alzheimer's dementia patients have family history. If your mother are demented, it will have 8 to 13% opportunity to inherit the possible AD to his daughter. And if your father are demented, the opportunity could be 4 to 6%. So in some way, there are hereditary opportunity of dementia people, especially AD. So we try to examine the possibility of very, very mild dementia in the children of demented people. So we call it adult children study. So in my clinical site, if your parents are treated at my site with Alzheimer's dementia, we are working for a further study for your children. So that's what we call the adult children study. Currently, the ACA study have spread to the Asian country and all Taiwan. This picture just tells us the brain agent. Some people we are brain agent and go into a step we call MCI, mild cognitive impairment. MCI is not a diagnosis, it just only report a status. A status will be going to AD, will be returned to normal, and we are going to no change stably. So the people who have MCI is the people at the risk of demented. So far, we are working for how to find people who have MCI. The copying picture will tell you what happened to the mind of dementia patient. A very famous painter working for a Coca-Cola company eventually have the disease of AD diagnosis. And he was brought to Italy, the Venice, to draw a picture. The picture report here is complete when he was normal, non-demented. That's only at the beginning. So you can see the water is flow. Many people crowd here. It's noisy, but unfortunately, when the stage 1 of demented, the water did not flow. Everything is calmed down. No people here. And for the second and third stage, you can see the change of the body shape, the appearance of yellow and red color. So don't be so happy if your patient have show you the red color or yellow color. It means he is going to progress. How about the complication of dementia? This complication of dementia is the most important issue to disturb the caregiver. Then have delusion, hallucination, depression, social isolation, and also have aggressive behavior and some dangerous behavior. And this is one is very important. People know the sundown phenomenon. Every day in the evening, when sundown, the people become agitation, become hallucination, become agitated. So the sundown phenomenon is the most disturbance problem to caregiver. This complication we call BPSD, behavior and psychological symptom of dementia. There are many symptoms based on the observation. You can see scream, agitation, aggregation, repetitive act, question, sexual inhibition, and also have a psychological symptom. Then have a depression, apathy, and a psychotic symptom. How about the prevalence of dementia in the world so far? I would say it depends. In the North American, a famous study we call the Yuan-Han study, they have found the incidence of dementia have declined over the course of 3 decades, although the factors contributing to a decline have not been identified. In the Asian study, you can find here the decline of a stroke, the decline of dementia will happen. So it means we can control dementia secondary to control the risk factor in high-income country. But in some low-income country or middle-income country, the poor control of cardiovascular disease such as diabetes and hypertension, it will lead to the increased prevalence of dementia. So I would say in this way, the dementia could be declined in high-income country because they have controlled the cardiovascular factor. But also it will increase in prevalence, especially in East Asian, especially in China and India, because it will consistent with the worsening of cardiovascular disease risk factor. So if you are going to ask me, how about the prevalence of dementia so far? I would say it depends. How about the risk factor for dementia? We can subgroup dementia into the vascular dementia, the Alzheimer disease, and dementia or other cognition impairment. Here you can see the age is consistently the risk factor of dementia, and also we call the non-disease modified risk factor. The genotyping ApoE gene is an important factor of risk factor for Alzheimer's dementia. And a lifestyle factor, education consistently is a protecting factor for the dementia. Smoking is a risk factor. The diet, we have to the low cholesterol diet, the higher omega-3 diet will be benefited for dementia. And also the homocysteine not too high, the increased physical activity will benefit for dementia. Control BMI. The hypertension is risk. The hyperglycemia, diabetes is a risk. And also the lipid disorder is a risk. How about the inflammatory? The inflammatory is risk for vascular. And we have many risk factors and protective factors here. Importantly, I will tell you a method to screen whether an individual have dementia. We call it a screen dementia tool. This is a left curve of dementia patient. One patient diagnosed dementia and eventually to death. The total cost is less than 12 years. So if you patient diagnosed here, you can treat the change will not be bigger. But you diagnose in a mild or even in the very mild stage, the change curve will be much more and more. So today we are going to highlight the importance of screen or diagnose people at a very mild stage. This picture may be more clear to tell you here. If this patient diagnosed here and screen here, treatment here, the change will be bigger. The blue one is bigger than this one. These people we call it delayed treatment. For some reason, maybe delayed diagnosis. So it's very important to tell you the early diagnosis and treatment and the intervention will benefit the people most compared to delayed treatment. This is our study that also tell you the treatment earlier may benefit the patient. The CDR 0.5 means the people at a very mild stage. The 1.0, the mild stage. The 2.0 is moderate stage. Treated at a very mild stage, the people can continue as it more than 4 years. This one just only 3 years. This one just only 2 years. So it's very important to tell you, diagnosis and treat earlier, the people will have more longer lifespan. But also do not forget, even these people we call very mild stage dementia in the clinical, the brain are full of many pathological findings. So that's I tell you and show you in the previous slide. Today we are going to screen the preclinical AD, try to avoid the pathological destruction of your brain, and also we have to recognize agent, because people sometimes we confuse here. Agent is not a preclinical AD. If you are agent, you are not an AD. You don't worry. But if you are preclinical AD, some people with preclinical AD will mimic agent. So you need a physician, a very experienced physician, to tell you you are agent or preclinical AD, because these are two different paths for a treat. This picture is just the original version of AD8. Today, I just only simplify and report the using of AD8. Importantly, this equation try to detect the function decline compared to your previous status. If you have a decline or report positive in the questionnaire compared to your previous status at least 1 year ago, if you change more than 2 questions, you could have very mild dementia. So if you are interested here, you can go into a website to be trained for AD8 using. This is an English version. I also have translated and validated into a Mandarin version. So here I will recommend that you use the English version or Mandarin version if you are prefer. How about the treatment and intervention? Here I will introduce some we call non-pharmacological intervention. Maybe you can call a multiple training modality. This data is very interesting, published in Nature. When we are going to sleep, we will have a specially dream we call lucid dream. The feature of lucid dream is you can recall the content of dream after you wake up, and you can have some control in your dream. You are aware the dream is not true, so you can understand your situation during dream. That dream we call lucid dream. The lucid dream is very important and have some feature. You can find the EEG. In lucid dream, we have some particular frequency of EEG, the 40-25 frequency. We call the gamma wave. So this finding tell you we use the external stimulation with the 40 frequency. The individual will have lucid dream. You may ask me, what did the Asian dream works? If you are meditation well, you will have a gamma wave, the same frequency found in the lucid dream. And the gamma wave will increase the cortex to make the cortex more thicker. And increase the thickness of cortex will prevent you from the destruction of demented. So in some study and research will tell you the meditation will benefit the cognition function, and also maybe will prevent the occurrence of dementia because of the gamma wave. This study recently published in Nature and in Cell is a very interesting and important study. A researcher from MIT, American, then used a gamma wave light into the brain of a mouse. The mouse eventually will get rid of a beta amyloid loading in brain, and no longer become demented. This study then just use the light and the voice outside the mouse. The mouse eventually will get rid of amyloid loading. This is a very important finding here. It means we can treat dementia possibly not through the medicine. You can through the light, through the voice, through the gamma oscillation, the gamma wave method. The Tai Chi and the postural stability is a benefit for your physical. There are many publications for Parkinson's disease and recently for the dementia state, published from the NEJM. But importantly, I will tell you, if you are demented, do not do exercise program too much. You just have to do the usual care. But this study comes from the demented people. If you are not demented, you can do exercise program much more, it's okay. But if you are demented, you just only do the usual care only, because the study report data here. A moderate and to high intensity aerobic and strength exercise training program do not slow cognition impairment in people with mild or moderate demented. So I will say in this way, if you are demented, you need the usual exercise program, not so many high strength program. Because the exercise training program provides physical fitness, but no noticeable improvement in clinical outcome. So if you are demented, don't do the high level or high strength exercise training program. But how about if you are not demented? This study we complete at the Gung Shan, the senior parliament. We use a music intervention, but honestly, we use 6大明咒 Om Mani Padme Hum, the voice and the music, and listen to the senior elderly. And then we have find the decline of memory, decline cognition will occur if you are listening to the Om Mani Padme Hum. This study is complete and report for aging people not demented. Another group we call the subject memory campaign not dementia. We use a multiple training modality, physical fitness, calligraphy, and meditation for 4 months. And we can see the improvement in senior fitness and the mood in both groups, and the improvement in recent memory in subjective memory campaign group. So I would say, if we are going to do the intervention for these people, the multiple training modality would be better. It means we have to use together. But how about the demented people? The demented people no longer listen to you for meditation. So for the training program, we don't use meditation for Alzheimer's dementia people. We use multiple modality we report here. You can see the improvement in CSI, the psychometry, and also improvement in the quality of care. It's very important we have published these books, because some people tell me, Professor Yang, you complete your research, but can this research help people? I think it is a very good question to me, because many Chinese people cannot recognize the SCI paper written in English. So I have translated this English paper and then make it briefly to this paper, from this paper to comic books. This book is painted and use a very important and simplified illustration and instruction to teach you how to do the non-pharma intervention. We have the copyright, but free use. If you are interested in this book, I will send you the electrical version. You can print it and use it in your site. And also I have 2 books. I'm sorry, I'm written in Mandarin. It's for the physician and also for nursing or for ordinary people. This one is the experience of care patient and report many stories and experience of AD patient. This one is teaching MOOCs how to use the AD8. I'm very sorry, during the pandemic situation, I cannot to discuss speak with you face to face. And I thank you for your attention. I have many works. I'm working for a neuroscience research center. I also for a perspective medicine, for Department of Neurology, for the Center of Teaching and Research and the Memory Aging Center. If you have any question, please feel free to email me. My email is very easy to remember. Endless. Thank you for your attention, and I will discuss with you later.
Thank you so much, Dr. Yang, for that presentation. I know you had also shared another video, a short 6-minute video. Did you want to show that, or would you want to just open it up for questions now?
Yes, I have another video to show Alzheimer pathogenesis and works. So can you play the video?
Sure.
Alzheimer's disease was described for the first time in 1907 by the German psychiatrist Alois Alzheimer. In performing a histopathologic study of the brain of his patient Auguste D, suffering from dementia, he brought to light the presence of 2 types of lesions in the brain, senile plaques and neurofibrillary tangles. He reached the conclusion of a distinct disease of the cerebral cortex. 100 years later, thanks to current scientific techniques, research has made a great leap in the understanding of the disease. We know that the brain is made up of neurons and that these are interconnected to form a vast network. These connections, known as synapses, enable the transmission of information from one neuron to another. In Alzheimer's disease, 10 to 15 years before the appearance of the symptoms, 2 main lesions form in the brain: senile plaques, composed of amyloid beta protein, and neurofibrillary tangles, composed of tau protein. How is the senile plaque formed? On the surface of the neuron is a large protein called APP. Normally, APP is sectioned by enzymes on the surface of the neuron, and it frees a protein called amyloid beta. The amyloid beta protein is then cleared in the body. In the case of Alzheimer's disease, there is an imbalance. The amyloid beta protein is no longer regulated and is found in too great a quantity. The proteins assemble to form indissoluble fibrils and create senile plaques. How are neurofibrillary tangles formed? When a neuron communicates with another, a signal goes from the body, known as soma, to the synapse to transfer the information. The signal passes through the skeleton of the neuron composed of microtubules. These microtubules are stabilized by normal tau protein. In Alzheimer's disease, tau protein becomes defective and detaches from the microtubules. Thus, the skeleton of the neuron dissociates as it is no longer maintained. Defective tau proteins then assemble to form filaments in the neuron. Without the skeleton, the neurons degenerate and connections between the neurons are lost. The abnormal accumulation of tau filaments in the neuron creates neurofibrillary tangles and eventually causes the death of the neuron. How do the 2 lesions spread throughout the brain? Neurofibrillary tangles and senile plaques do not follow the same pathway in the brain over time. Neurofibrillary tangles first develop in the region called the hippocampus, which is essential to memory and learning. They then reach the whole brain following a centrifugal movement. The process causes atrophy, which engenders global dysfunction. The progression of the lesions corresponds with the symptoms of the disease, which begin with memory problems, followed by problems of language, recognition, and incapacity to perform gestures. Senile plaques develop differently. They are initially observed in the cortex, secondly in the hippocampus, and then the senile plaques reach the whole brain following a centripetal movement. Their progression does not correspond to the symptoms of the disease. But numerous questions remain unanswered. We know that the presence of the two cerebral lesions is necessary to develop Alzheimer's disease, since one does not come without the other. But which lesion comes first? Neurofibrillary tangle or senile plaque? The answer is still under debate. Many clinical trials destined to reduce senile plaques in the brain have failed. In fact, reducing them is not sufficient to eradicate the disease. It has now been suggested that well before formation of senile plaques, smaller forms of amyloid beta called oligomers appear to be toxic for neurons, disturbing their communication when they fix onto synapses. It would appear that the toxic oligomers and their accumulation in senile plaques are at the origin of neurofibrillary tangles, which in their turn are responsible for symptoms. The relationship between amyloid beta protein and tau protein is still little understood. What is the exact sequence of molecular mechanisms leading to the development of dementia? What is the role of genetics and environmental risk factors in the appearance of the disease? Scientific research is essential in answering these questions. Thanks to researchers, Alzheimer's disease is better and better known in its complexity, and new avenues raise real hope for the eradication of this devastating disease.
Okay,
Yes, I hope everyone can understand the pathogenesis of dementia and how to screen. I would say it would be beneficial for everyone.
thank you. Maybe we can open it up for some questions. So if anyone has a question, you can post it in the chat, please.
So there is no question.
Not yet.
So I will ask one question. Do you feel your memory is good or not? How can you detect your memory decline if you have? Can someone answer this question?
Can you repeat the question? You had said, if my memory is good or not, and what's the second question?
How can you detect that? How can you detect your memory decline if you have?
So how can you tell memory decline over time?
Yes, how can you detect? How can you know you are under a decline of memory? How can you know that? If you have a symptom, memory decline. Or everyone consider you are very good, very well in memory.
Good question. I have no idea.
Yeah, you have no idea. But actually, it's a question. Because many times, many physicians come to my office and ask me, did she have a memory decline? I would say it's not easy to compare to other people. So I introduced the screen tool AD8, try to help everyone to know, did you have memory decline? So the main problem is the memory decline associated with your impairment of daily activity. If this impairment occur, I would say the memory decline is meaningful. But if it did not doesn't matter, it will not be meaningful. So it's individual and depends on yourself.
Thank you, Dr. Yang. There's a question in the chat from Leslie. If symptoms start 10 to 15 years after dementia has started to form in the brain, what can people do to lessen the chance of developing dementia?
In my talk, I would say we know that dementia could be occur very, very early before a symptom. It could be occur 20 years before the onset of symptom. So if we are going to detect this change, it's not easy to use the clinical symptom. We have to use a biomarker. The biomarker may come from the genetic biomarker and the neural imaging and the protein. So if you have you are under risk of dementia, I would recommend that you can go to the office to check a biomarker before the onset of symptom.
And are there any behavioral things that you would recommend or social things that you would recommend?
The symptom of dementia could be, I would say the cause of dementia will be the onset of dementia and the preclinical cause. The preclinical cause is not easy to recognize by physician. So you have to go to the office to check the biomarker. And for the prevention of dementia, I would say I would recommend meditation because it's a time saving and money saving, and also is effective. The meditation currently will consider to be the innovative intervention for dementia. But so far, we know the treatment of dementia, every study is failed. Even the Maldian study in America is failed. So the MIT and Harvard then consider other physical treatment intervention, such as gamma wave. So the data of the clinical trial published in this May, and it shows it's a promising improvement after the meditation and the gamma wave intervention. So far, for the clinical cause of dementia, we recommend that if you are under risk of dementia, you have to go to the bio lab to check the biomarker. And for the intervention, I would suggest you can do that in your home. You can use meditation. Because even if you are not a dementia, you can do the meditation.
Thank you. And maybe one last quick question from Tom. Are the side effects of the medication worth the risk? What are the side effects of the medication for mild AD?
The side effect of meditation. The meditation, currently there are 4 medicines for Alzheimer's dementia. We call the donepezil, the Aricept, the Esteron, the rivastigmine, and the galantamine. The most important side effect could be nausea, vomiting, and dizzy. Some people taking this medicine would be anorexia, the poor appetite occur, and have a gastrointestinal problem, such as diarrhea. So if you are not demented, I don't recommend that you take this medicine. And eventually, some physicians use the Nimantine, the advanced medicine for early dementia. He also don't recommend, because if you use the advanced treatment for the early stage, it will worsen the clinical course and will not help the patient. So don't take this medicine if you don't have demented. And even you are demented, you have to visit a professional physician who are skillful and experienced in this treatment. All these medicines are different.
Thank you. And
Thank you.
We'll take one more question. from Lee, I saw a research program on dementia in the UK, and they suggested that social interaction could lessen the chances of getting dementia. They also added meditation as a tool.
Yeah, I see the UK is quite, just be honest, the UK is quite different from America. The UK consider the meditation, I would say the all Europe consider the meditation or natural intervention will be benefit from the dementia prevention. That's quite different points of view from American. So in UK, then consider the meditation, but you have to do the useful meditation. It means during your meditation, you have to have the gamma wave occurrence. Some meditation have many measures, and you have to find a good instructor to teach you how to do meditation. And currently, we also can measure the brain function during meditation. If you are going to the meditation course, the brain will have a gamma wave. So if you don't have the gamma wave, it means you have to learn more how to do the meditation. So far, we have objective measurement for the meditation, but don't forget that it takes time for meditation to prevent dementia. It at least takes years, not months or days. So we have to do meditation every day and continuously.
Thank you. And just one more question from Christine. Thank you for the informative presentation. As the later stage of dementia prevents additional learning and memory, how do we bring comfort to a dementia patient with the fear of losing their memory? The conversation of reassurance is forgotten repeatedly, causing distress.
I would say we have to pass the journey together with the dementia patient. If this patient is in the very mild stage, you can consider the patient is your friend. You can share the story with your friend. You can travel with your friend. But if this patient become moderate, he is no longer become your friend. He could become your children. So you have to take care of the children. And now eventually, for the patient become more advanced or severe dementia, I would say it become your grandson. So you have to take care of him. So different stage of dementia, the caregiver have to play different role. Do not consider we are consistent role to the dementia patient. So for this patient, you have to change your position. You have to change your role, you have to become a patient to check what you need. So I would say changing position, replace position to be a patient, it will tell you how to do for the patient and how to care the patient. Change position.
Thank you so much, Dr. Yang.
Thank you.
Yeah, I think we all learned a lot. Venerable, would you like to?
Yeah. Thank you again, Dr. Yang, for your time and also sharing so much information about dementia and also like the preventive measures in terms of like getting to know dementia earlier. We also thank everyone who joined us tonight. Before we end our talk, we will do a short dedication and merit for today's session. So if everyone can join our palms, and I'll do the dedication and merit. May kindness, compassion, joy, and equanimity pervade all worlds. May we cherish and build affinities to benefit all beings. May Chan, Pure Land, and precepts inspire equality and patience. May our humility and gratitude give rise to great vows. So I'd like to pray and hope that everyone continue to stay safe. And again, I would like to thank Dr. Yang for your time and also the sharing. So we hope maybe one day we can see you in person after the whole pandemic. So thank you again. Amitofo.
Amitofo. Thank you.